Okay, I think everyone's here.
Yeah, we got everybody. No slides yet on our end.
Perfect. Yeah, very good. Um, Let me share. Uh, okay, can everyone see my slides?
Yeah, perfect.
Who is not driving? Is anyone not driving?
I'm not driving yet.
I'm not
Yeah. Okay.
driving.
Oh, good. Okay. Heather, are you here?
Yeah.
Oh, wow. Okay. I'm in room five. Four. I'm in four. Anyway, okay. All right. So we're gonna do a talk on abdominal trauma in sports. So, obviously, with my background, this is kind of more in my wheelhouse is all this trauma stuff. So, I like giving these talks because they're really easy talks to give. You guys know who I am. I'm not gonna do that. Disclosures. This is what I used to say. I used to say I failed you. I have zero disclosures, but I actually do have a disclosure now that has absolutely no relevance whatsoever to the talk. So I'm a key opinion leader for Trice Medical, and that's it. So our objectives today are to learn the incidence of abdominal trauma in sports, to understand the evaluation of abdominal trauma, and discuss imaging and return to play and all that kind of stuff. Okay. Um, we couldn't talk about every single type of traumatic abdominal injury because if we did, we'd be here for like an entire day. So I tried to pick the big one. Okay. So looking at epidemiology, look at the injury registry. So this is actually a really sweet system, and I think about 100 different papers have been actually published through this system. A couple of them I've been part of, but basically, like the Ohio High School, or not Ohio, sorry, the high school and NCAA collegiate athlete injury registry. It's like three different systems that they put this big conglomerate in, and they use this for like epidemiology of all these things. It's a little bit outdated at this point, but I still think the data would be pretty similar now. So by far, the most common injuries are musculoskeletal sprains and strains, no doubt. Head injuries are second most common, particularly concussions and whatnot. Abdominal injuries are far less common. However, abdominal injuries, when they do occur, they can be classified as catastrophic. Okay, so and by catastrophic, we mean severe, temporary, semi-permanent, or permanent disability, or even death. So these are pretty dangerous injuries. Um, Hopefully, if they are things, they're small things, but they can be absolutely devastating. So these are things you definitely don't want to miss. Okay, so like sideline coverage, things like that. These are pretty gnarly things. Okay, so during the 10-year period, 174 abdominal injuries, 124 in high school, 41 in college were all non-catastrophic, and then nine catastrophic. Which again, not a lot, but all it takes is one bad one in your career, and you'll never forget it. Okay. Highest rates are no doubt in the male contact sports. So football, and I should actually put in here American football, lacrosse, and ice hockey, no doubt. And obviously these are guys sports because guys are dumb and hit each other. So most organs. So it depends on what paper, what textbook you read. Kidney is usually around three. Spleen and liver, depending on which textbook and which paper you read, are kind of split between one and two. I would argue that liver is probably the most common. Spleen injuries, I feel like me personally, I've had more spleen injuries than anything or splenic injuries, but liver is also very high in the differential. So these are kind of the big heavy hitters. And as you go down, small bowel, large bowel, obviously, bladder less common, diaphragm, what have you, and all that kind of stuff. So, it really encompasses a huge array, but these are the big ones we don't want to miss. Okay. So let's talk about sports equipment. So, where were we back in the day when they did joust and they did all these crazy sports? They had a lot of protection, they had helmets, armor, chest protection, belly protection, all that. Now we got this, and our equipment's even getting less. So like when I played football, we had big shoulder pads and big helmets, and we had cowboy collars and we had rib protectors and all these things. And now you're like seeing less and less and less. And the equipment that they wear now is like I feel like half the football players outside of a helmet is like paper thin. So a lot of exposure here. Okay. So when we think about hockey, so hockey is obviously near and dear to my heart. Um, they have a lot of coverage around the chest, around the shoulders, arms, wrists, ankles, all those things. But the belly is exposed. And the reason for that, obviously, is you can't really put something stiff around the trunk when you need to and what have you. So just know that it's like always exposed. Looking at lacrosse equipment, again, they do a great job protecting the chest, the shoulders, the arms, the head, belly, flank, totally exposed. Okay, and these are the injuries, or these are the sports where you see higher rate of injuries. One, because of coverage, and two, because of the actual nature of the injury. Okay. So me personally, when I give talks about things, I can't stand just sitting here and showing PowerPoints and talking for 30 minutes to an hour. We're not going to do that. I like to do case presentations. And so you guys know I like to ask questions too. So just please be ready to answer. Otherwise, I'm going to call on you guys. So it's one of my favorite quotes. I always like to do this for M&Ms and pretty much everything is a smart man learns from mistakes, but a wise one learns from others. So, or a wiser man learns from others. So I like that because this is, learning from cases, seeing and these are all my cases that I've gone through, um, will kind of help you get an idea of things I may have done well and things I may have not done well. Okay, so first case. So this is a 19-year-old male professional hockey player. No past medical history, checked in the wall during a game and begins leaning over holding his belly. So I'm going to show a video. So hopefully not everyone's driving. Anybody can watch this video. And it's a real easy injury to anybody see that up at the top there? I know I need to shorten this video. I don't know how to do it. So if you look at the top of the screen, just play right here. Boom. See that? Can anyone not see that?
Got it.
Okay, wonderful. So I was working this game. I was sitting in the tunnel over here, and I remember seeing this player. So he was a player from the other team. So he was a Laval player from Canada. And I remember watching this occur, and all of a sudden he got hit over the boards, and I saw him reach for his belly and then kind of skate off the ice. Generally, when this happens, how my approach is I kind of sit in the tunnel and I kind of look back and see if they bring the player off the bench. And if they do, then we go back and check them out. Because as you guys know, we cover both home and away teams. So never did. And so at intermission, they actually called I was seeing another player for concussion, one of our players. So I was evaluating him, and then they called Cross and Jared, our ortho, they called him and asked him to come evaluate this player for abdominal pain. So naturally, if you guys can imagine, he was a little uncomfortable. So we went and saw this kid, and then he grabs me. He's like, "Hey, I think he's got a bad rib injury, but I just want you to check out his belly." Oh, no problem. So I walk in there, and then I was talking to the player, and I was like, "Hey, like any recent illnesses and whatnot?" And because the trainer had said he had recently been sick, so I asked him. I said, "Hey, what's this recent illness?" He said, "Oh, I had the flu 2 weeks ago." And I asked him how do you know it was the flu? He's like, "Oh, they just told me because I had fevers. I didn't feel well for a week, and then I felt fine, so they probably had a flu." Okay, so this is in Canada where testing is not as easy as to do here. So here's exams. I got some vitals on him. Everything looked pretty good. Good vitals, respirations, all that stuff, heart, lung, all those things were fine. His belly exam, non-distended, no ecchymosis, normal active bowel sounds, no rigidity. He did have mild tenderness of the palpation of left upper quadrant with rebound tenderness and voluntary guarding. Okay, so what's I hope I didn't give it away too quickly, but what's everyone's plan on this one? Or does anyone want to volunteer? What you would do?
I mean, left upper quadrant, concern for spleen injury, and then just kind of like the history of recent illness, wondering if it's like a history of mono recently without the testing.
Yeah, exactly. And that was like literally the first thought I had. So I kind of talked to the player, I talked to the team manager, and I was like, look, this kid needs to go to the hospital. I'm worried that he has a twin injury. They're like, well, he looks fine. I'm like, well, he looks fine now, but he may not look fine soon. So we walked him. So after a little deliberation, they finally agreed. We walked him to the ambulance and they pushed back, like, he's fine, nothing's wrong with him. And I was like, nope, trust me, he's got a spleen injury. So I did send him to the ER. And then here's the CT. So, and I called the ER doctor, who was on that time. It was Vicky Noble, who I've known well for a long time. And I said, "Hey, kid, I'm almost certain he recently had mono. Can you please check him for mono antibodies and get a CT of his belly?" So he did. He had a nice, I want to say, if I remember correctly, grade 3. We'll look at the radiology report here in a minute, but a grade 3 liver lac, or 2-3, I think it was. Here, you can see an obvious laceration to the not, I'm sorry, it's the liver, but spleen is what I meant to say. And then he had a belly full of blood. Okay, so he remained, oh, grade 3, I was right. So he remained stable. And luckily there was no active extrav from by the time he got there. So he did have splenomegaly on imaging. So and he was EBV IgM positive. So he had active recent mono infection. It was a great case. Like, how many times do we see that, right? So we talk about it, we read about it, it's on our boards, but like, how many times we've actually seen it? One time for me. So Here's the splenic injury classification. I will never remember this. I don't expect anybody to remember this. Just know grade ones are small injuries and grade fives are like total destruction. And I'm almost certain when the radiologist reads these images, they don't know the grade either. And I'm almost certain everybody who reads anything has to look up the actual classification because who's going to, right? So no, higher grades are bad. Okay. But he did well, but he was managed non-operatively. He did stay in the hospital for a couple days. They monitored his H and H. At no point was he ever unstable, and he did well. He did well. This was actually like literally a week before COVID. And so like he was out for the remainder of the season, which he probably would have been anyway, because we were kind of three-quarters of the way through the season, but then like everyone was out for the remainder of the season after that following week. Um, so I don't know what his return to play ended up being because he wasn't my athlete, but I imagine 3 months ish is kind of the guidelines. We'll kind of talk about that, and they're very vague guidelines at that. The treatment for these. So hemodynamically stable patients with blunt trauma can usually be treated as observation. Okay. It's not based on injury grade alone. So grade of splenic injury plus vitals plus clinical impression, all those kind of things. So generally, if you see this kind of injury or you have suspicion for this kind of injury, send to the hospital because almost always, if they find it, they need to be admitted and they can be kept overnight, at least one day, so they can monitor all those things. Okay. Um, if bleeding is present but patient stable, consider splenic embolization. Higher grades have higher rates of failure non-operatively, essentially 4 or 5 compared to 1 through 3. 1 through 3 generally do well non-operatively, whereas 4 or 5 usually need some type of intervention. Um, Hemodynamically unstable patients, urgent laparoscopy and likely splenectomy, full or partial splenectomy. So that's your general guideline. So case number 2. So this one was a 17-year-old high school football player hit while making a catch midfield. So I'm going to play this video. This one's a little more obvious than the last one. So he goes up for a catch and just gets absolutely crushed. So I was the doctor on the home sideline. This was a visiting player. This again. Okay. So, um, so I was then called to go to the opposing sideline because we watched this kid kind of like same thing as that hockey player, grabbed his belly, slowly walk to the sideline, and I was thinking to myself, that doesn't look good. And the other trainer had our trainer's number, so she called him and said, "Hey, can you come check this? Can you send the doctor come check this kid out?" I'm a little concerned, which rightfully so. I was concerned just watching from afar. So I examined him. Obviously, I had less. I didn't have a machine there to get vitals on the sideline. So I went to see him over there. He was in mild distress. Everything else normal, five, all the heart and lungs were fine. Of the abdomen non-distended, no ecchymosis, normal bowel sounds. He was diffusely tender, more peri-umbilical. He had no guarding, no rebound, but he was pretty tender. And so this was kind of an also annoying thing. By the way, a lot of these things, when we have like a concern, like it's always like us fighting everybody else, trying to do the right thing. Because everyone else is like, they look fine, there's nothing wrong with this kid. So I literally had this long conversation with the trainer. I said, look, I'm pretty worried that he has a belly injury, really tender. I was like, one, he should not return to the game, and two, we may want to consider him to send him to the hospital. And her response was, I'm not doing that. You need to go talk to the coach. And I was like, what? This is like the weirdest interaction I've ever had with a trainer. It was a Cleveland Clinic trainer. And I'm like, you know what? I'm not even gonna, I was like, I'll tell you what. I was like, it's your kid, but I'll tell you right now, if you put him back in the game, that's fine. But if there's one slight issue with this kid, I'm literally superseding. And so what they do, they put him back in the game. And then, which I don't have a video of the second hit, unfortunately, but then he made a catch like literally 4 plays later, made a catch and got hit in the belly again by one of our defenders and started, he was then on their sideline retching and vomiting. Okay. So who's doing what's everyone's plan at this point?
Send him to the hospital.
Yeah, pretty obvious, right? I know, super talking. I sent him to the ER. And literally I got pushed back from everybody again, and the ambulance crew. It was like Billy Bob and his crew, and they're like, we're not like this kid looks fine, his vitals are fine. I'm like, I get it, but like something's going on with this kid. So I later found out that they did send him to Hillcrest and he was found to have a large bowel perforation. So far less common injury, and apparently his belly was full of air. So that was just the follow-up I had from their trainer calling our trainer. I and then something else to realize here too is once you guys send an athlete, once you transfer to EMS, unless it's like one of your established kids, you actually can't like follow the records. You can't do any of that stuff. Once it's out of your hands, you're done. So really lost a follow up for me. However, again, it's one of those things that you got to have a high index of suspicion because people will fight you all the way because these athletes, they're healthy, they're fine until they're not fine. Okay. And so and for me, I'm always thinking worst case scenario, what's going to happen if I didn't send this kid? Well, if I didn't send this kid, holy crap. Like, he would have probably done pretty poorly. So I'm glad I sent him. I don't know what I don't know if he had a resection. I literally have no idea. All I know is that he had a pretty dramatic injury. Okay. So, and again, stand your ground. So, another case, number three. This is a 28-year-old male NFL player, says during training camp. No history, presented in the training room after practice with a complaint of abdominal pain. He states that he was tackled and struck his abdomen and ribs on a helmet of another player. So he was tackled, went up for a ball, tackled, and then landed on top of another player's helmet. He finished practice. He had no issues. And then after practice came, he's like, "Yeah, I got this like vague pain in my upper abdomen, eating eyes, chest pain, shortness of breath, cough, back pain, all those kind of things. No nausea, no vomiting." So we got some vitals on him. Vitals were totally fine. He looked fantastic. Abdomen again, non-distended, no ecchymosis, normal bowel sounds, no rigidity, very mild. And I put this in the cap, very mild right upper quadrant tenderness, no rebound, no voluntary guarding. No, so like he looked great. And I was me personally, I think I was a little bit biased by this because he looked so well and he finished practice. And I'm like, nothing's wrong with this kid. I was like, but we probably should get him imaged because and now in retrospect, thinking this is training camp, this is a bubble roster guy. And so he was gonna try to play through anything. And as you guys know, you guys have kind of worked with in the professional world, you know who's going to play through things and who's not. This is one of those guys who's going to try and play through anything. And so begrudgingly, we had a lot of discussion. I was like, look, we probably need to send him to be safe, but I was like, it's going to be negative. He'll be fine and he'll return to practice tomorrow. Well, I was surprised. So he had, so look at the image here. Here's the liver. He had multiple lesions or multiple aspirations. And then again also had blood in his belly. So at that point, so we don't have to get into all the details of this, but long story short, he had a grade 3 liver injury. Okay. The good thing is, again, he had no active extrav or anything like that. But and although also the funny thing about this is we got this as an outpatient because we were so convinced that nothing was wrong with him. So then we had to figure out how to get him from. So he went, got the imaging, came back to the training room, literally because it's like down the street where they get the imaging. And then I saw him in the training room. I was like, shit, we need to send this kid to the ER. And so then we backstepped and we sent him to the ER. Again, liver injury classifications, splenic injury classifications, they're actually pretty darn similar. Just know there are, again, 6 grades, anywhere from 1 to small, 6 monstrous, and total avulsion in the liver. I've never actually seen that. I don't think I've seen any liver laceration greater than a 4. But I think they do exist in high velocity traumas. So anyway, we sent him in. He got him into the hospital. I want to say he was there again for 2 days. They monitored H&H. He remained totally stable. And then the question was, well, what's the return to play? Okay. So the general recommendation is not to repeat imaging over and over and over, but with these players, it's a totally different animal. And so he got repeat imaging 4 weeks later, resolution. But then he had an ultrasound 4 days. So he initially had ultrasound 4 days after the injury. They revealed healing. He had the repeat CT 2 weeks after, which showed interval healing. Then he had another ultrasound 3 weeks after that, and then another. Okay, so 4.5 weeks after the injury, he was cleared for full participation. Okay, again, the way these players are managed are way different. If this was a high school kid, I would probably not try and push him back this fast. I probably wouldn't get all this repeat imaging. But it's just, again, it's a different animal when we play with these level athletes. Okay. So 4.5 weeks after a liver laceration is pretty darn good. Okay. Any questions about that case? And by the way, this was in full disclosure, this was a near miss by me. I was wildly convinced nothing was wrong with this kid. So anyway, okay, case four. So this is a 26-year-old professional hockey player. This is actually one of our players. This occurred in Charlotte, so I had to put all this stuff together afterwards. But I'll show you the video. It's pretty wild. So, 26-year-old male professional hockey had a left-sided shoulder pin impact mid-ice. Initially returned to the bench complaining of left abdominal wall pain and kind of rib pain, from what I was told. Here's the video. We're looking at number 25 here. Does anybody see it? I'll show it again. Anything jump out at anybody there? Anybody? Bueller? Okay.
I
Watch
would
it one more
just
time.
argue it didn't look like that significant of a hit.
Yes, it looked like nothing. This is like even one of our lower velocity injuries, right? Watch this. Boop. Like, how many times do we see that in a game? Probably 300 times. I mean, that's a bit of exaggeration, but a lot. Like, this is not something like we've gone through this so many times, and it was literally a nothing. Ironically, well, before we get deep into this case, I saw this player 2 weeks before this happened for a viral syndrome. And me, especially with what I've experienced in the past, I give players about 7 days. If they're not getting a lot better, like with their viral syndrome in 7 days, he was sick for about a week. I check him for mono. So I did test him for mono. And again, when I test for mono, or I shouldn't say again, but of note, when I test for mono, I don't just do the mono spot. I always check the type or the antibodies because I want to know if it's chronic, new, all that kind of stuff because does affect return to play. Okay, so I saw him 2 weeks prior to this injury and totally fine. Mono testing, everything totally normal. All of his viral testing was negative. COVID, flu, you name it, he didn't have it. And then we just chalked up to some rhinovirus and he did fine. So he was in Charlotte, had this tiny little injury, crazy. And it turned out to be like one of the most chaotic things. That was it. Okay. So they called the orthopedic surgeon to see him during intermission, which, yeah, because it didn't look like anything abdominal. He was like, in talking retrospect, and he's like, yeah, I definitely had what's called the Kerr sign. I was like, yeah, actually, I would definitely agree with that. So surgeon saw him. His complaint was more like rib, belly, shoulder kind of pain. So they diagnosed him with an oblique strain and maybe like a rotate shoulder contusion. They sent him back to the game, and then he tried to play and started getting left upper quadrant, left lower quadrant, pelvic pain, and then he started having nausea and then started vomiting. I want to say it was second period where he tried to go back out and started playing. Then he started having all these issues. So then our trainer pulled him off the ice, sent him to the locker room, and then the player texted him like, "Hey, something's going on. I'm sick. I'm vomiting. Like, I don't feel good." Okay, so then they had the medical doctor see him, and the medical doc evaluated him, and then said, "I think he's fine. It might be a bruised spleen, but you guys can fly home tonight." And luckily, our trainer was like, "No, you can go fly a kite. We're sending him to the ER." But luckily, their stadium was close to a level one trauma center, thank God. So then they sent him to the ER, straight from the arena, right at the end of the game. And then he had a pretty significant injury. So if we're looking here, he's got I want to say I think in the end, it ended up being a grade 5 splenic lap. Tons of blood in his belly, huge laceration, capsular hematoma, um, active extravasation, and just, again, a belly full of blood. So, yeah, they call it grade 4 fail. Laceration with active bleeding. So he, in here, he actually was pretty unstable when he got there. I was going through all of his records. His heart rate was in the 130s. His blood pressure was like 100 over 60. He was pretty sick. So what they did, they felt that he was stable enough, so they actually sent him to IR that night for embolization. His hemoglobin dropped all the way from 14 to 7.2. So he actually did receive a few units of blood. And then he kept kind of being very unstable throughout the night. So then they sent him for a repeat CT angio the next morning, and it did show. So you can see some contrast here. Again, belly full of blood. You can see these. Anybody know what these bright specks are here?
Probably the coils.
Yeah, so these are the coils. So you can see where he got coiled. Um, and then so his repeat CT angio is negative for active bleeding, but he kept dropping his, from what they could see, but he kept dropping his hemoglobin. They were actually planning on taking him either back for, and I talked to a trauma surgeon after all this was said and done. They had him scheduled for repeat angio the next morning, but they were also had an OR prep because they were actually planning on doing a splenectomy if he didn't finally stabilize. So, which I'm very happy they didn't because they were really close. So luckily he finally slowed down, and I think he more than likely was just trying to catch up from all the blood that he lost. So he's getting transfusions. Finally, his hemoglobin stabilized, and then he was discharged a couple days later. Okay. So I saw him in the office the following week, continued to have tenderness, but overall doing much better. He's tolerating food, all that kind of stuff. So returned to play for this. So, and this was like kind of mid-season when this happened. So really the plan was to avoid contact for the next 3 months. So this was a season-ending injury. Light activities after 2 weeks, then full non-contact was tolerated. Um, I worked really closely with Dr. Anders with this, and we kind of were debating on how much we could let him do. And Anders is just like, yeah, I mean, after 2 weeks, he's like, you can start doing stuff. But we were very specific to have absolutely no contact. He did have a repeat CT 3 months later to evaluate for resolution of injury and to make sure he didn't develop any aneurysmal disease. So I guess that's a high risk. I was talking to Anders about this. So post these traumatic injuries, it's not uncommon to develop aneurysmal disease, and that's why they like to get repeat CT imaging prior to full return. So we did that. His repeat CT, I forgot to put in here. Show it's like basically the necrotic part of the spleen that was embolized. Otherwise, I want to say 3/4 of the spleen was totally functional. So I didn't vaccinate him or anything like that. I felt like he was not immunocompromised at that point. Um, so then we let him return after 3 months, and then he had no issues at all. And he was with us last year, but then got traded, but he's still playing. So treatment with these, in general, stable patients with blunt liver spleen trauma can be true of the odds. Greater than 90% success rate with this management strategy. Usually monitored unit, and usually by that, like ICU. Recommend abdominal exams, H&H's, all that stuff. So basically, just send them to the hospital. We talked about embolization. If bleeding's present but patient's still stable or peristable, they can get embolization. But if they become unstable, they're going to need a laparotomy or laparoscopy. Less than 3.5% fail non-operative management, so pretty low. So they usually do pretty well. Higher failure rates, as we talked about, with higher grades and more non-operative success with lower grades. And unstable patients, like we talked about, urgent laparoscopy or laparotomy, depending on the situation. Okay. So when you talk about return to play for these, there are no true guidelines. So, it's kind of, when it comes to this stuff, I kind of lean on my trauma surgeons with this kind of stuff. Like, what's your plan? What's our plan? We always have a discussion to decide. I feel like the general rule of thumb for all of these things is 3 months. Who decides that? Who knows? I feel like someone just randomly came up with that a long time ago, and then everyone just kind of follows that. So, but knowing, like, we had our football player who got back in 4.5 weeks, but he also had a lower grade injury. Whereas our higher grade injuries expect 3 months, and that's exactly what we did for our bad. So, you can't be wrong with 3 months. Certainly, you can push a little bit faster depending on the situation. Lower grades can get back a little bit quicker as long as they're stable and doing well and do a slow progression. Higher grades just expect 3 months. Okay. So let's talk about sideline evaluation. ATLS, 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 ATLS. Like, remember that missing this stuff is really bad. Okay. So just have a very high index of suspicion. From my experiences, people are going to fight you. Okay. Um, Players, again, because they're in fantastic shape, they can compensate hemodynamically for a long time. And so they're going to look fine until they don't look fine. I mean, looking at our hockey player in Charlotte, he looked fine. And then by the time he got to the hospital, like, had this kid tried to fly, he would have died on the plane. No. So have an initial suspicion. So in general, for abdominal trauma, look for damage of overlying skin, subcutaneous blood vessels, ecchymosis, all those things. Assess for immediate worsening pain, local versus diffuse, stationary versus radiating. Immediate, getting worse, bad. Local pain, is one thing, but once it becomes diffuse, you worry about peritonitis, and so you worry about blood, air, all that kind of stuff. stationary pain rating, all those things. Okay. That's regarding rigidity, rebound tenderness, peritoneal signs. There's any peritoneal signs, just, the way I like to approach this is I think to myself, if I'm seeing this patient in the ER, am I imaging them? The answer is yes, then I send them to the hospital. And it's really tough for me, especially being an ER doctor. I feel like I've been defeated if I send someone to the ER for my colleagues to handle. But I'm going to do it. If I'm in the ER and I'm seeing them and I'm going to order the imaging, then to me, I got to send them because it needs to get done, right? This isn't something you want to work out as outpatient. Okay. Certainly clinical signs of decompensation, cold sweats, confusion, loss of consciousness, lightheadedness. They don't look good. Just get into the hospital right away. Okay. These signs, first sign is shoulder pain. Colon sign is periumbilical discoloration, and Gray Turner sign is flank ecchymosis. Okay, just know those things. I feel like those are signs that are like easy hits on tests and things like that. Important for early imaging. Early grading leads to appropriate early management. Okay. In general, once they get to the hospital, CT in stable patients, ultrasound in unstable patients. So the reason I mentioned that is a common question I get is, would you have ultrasounded this guy in the ER, or I'm sorry, on the sidelines, like any of these guys, if you had an ultrasound, would you use it? The answer is, if I'm pulling out an ultrasound, if my concern is high enough to pull an ultrasound and image him, like they need to go to the hospital. Like I just, that means they're getting a CT. That means they need to go. If you're comfortable enough to pull an ultrasound out and look at yourself and say, hey, I'm okay with this, and they want to say, by all means, I have done that in a professional event before, but it's one of those things like you better be pretty darn confident. If I'm pulling an ultrasound to look at something belly, it's basically to show the player, like, look, you're fine. You can go back and play. If I'm like, oh my gosh, what do I do? And I'm pulling out an ultrasound, I probably need to reevaluate myself. Okay. Just rely on your exam. A negative scan early is preferable to a positive scan while the patient's decompensating. Not sure if you're on the fence, just send them to the hospital. Don't want to be chasing your tail later on when now all of a sudden they're decompensated. Then you're in trouble. Okay. Learning points. You're a sports medicine physician, use your instincts. Everyone fights you all the way, no matter what. Someone's going to doubt what you're doing. It's just the nature of our job. Our job is to focus on the athlete, focus on the patient. I don't care what anyone else says. I'm worried. I'm doing what I'm doing, and I don't care. I'd rather be wrong on a good side than to be wrong on the bad side. Okay. ATLS, ATLS, ATLS. Have a high index of suspicion. Missing a catastrophic injury can be catastrophic. If it's on your differential, address it. Early diagnosis is key to improved outcomes. Again, don't figure this out after the fact. Okay. References, questions. Sorry, I know that was a bit of a whirlwind. Okay. I will take everyone's silence as you're done. On that note, we will all go to work. Everybody have a great day.
Thanks, Ben.
Thanks, Ben.
You guys.